Hello everybody, and our next lecture is going to be on the assessment piece that really focuses on the cardiac system. So at the beginning of Unit 1, we had a similar lecture that included all of the pulmonary assessments. Let's focus now on what we can do within the cardiac realm. So just like in the pulmonary assessment, you want to kind of start going head to toe, and you first walk in and you make your baseline inspection of your patient, or your baseline, just what do they look like from the most kind of aerial view. And it's important to take into account their level of consciousness. And while you can check in with nursing and see how the patient is doing and how they're following commands, there's a much more objective scale, and that's the Richmond Agitation and Sedation Scale, or a RASS score. As you can see, the RASS score gives you different, a numerical value to represent whether they're awake or sedated. And then on the other end of that scale, awake but maybe agitated, which is a common reaction to medications they might be on or withdrawal symptoms they're experiencing. And it's helpful to know what you're walking into. So a 0 is your neutral scale. You are alert and calm. So you can pay attention, you can follow commands. 0 should be kind of baseline for all healthy adults. The more sedated you are, you get a negative number. So a -3 is moderate sedation. They move to voice command, but they're not making eye contact with you. And then -5 would be unarousable. On the other end of that scale, if the patient is alert and awake, but in any kind of an agitated state, they would get a positive number. So +2 represents agitated. So there's like unpurposeful movement. They're not matching up with their ventilator well, all signs that they're agitated. And then a +4 is when they're kind of overtly combative. So a +4 would probably be a patient that you would not see. They are violent and possess or are giving immediate danger to the staff. So that number gives you a lot of information in a really quick check, which you would be able to see their RASS score on any patient. So then you take in their general appearance. So in the pulmonary lecture, we really focused on aspects of their general appearance that might relate to pulmonary symptoms. But here, let's just talk about general appearance that might give you a window into their cardiovascular health. And their body type is the very first one. At this point, I hope you guys are familiar with the analogy of the pear and the apple, and that somebody who carries more weight in their abdominal region has a greater cardiovascular risk profile. In PathoPhys, we really went through the why of why carrying additional adipose cells in your abdomen are so bad for you. And if you remember, we talked about the fat that you store in your abdomen is actually a different kind of fat than the fat you store in your thighs or buttocks. The fat cells that like to live in our abdomen have a higher rate of producing inflammatory cytokines. So it creates a greater systemic inflammation, as well as the location of that fat is really important. When fat is broken down, the free fatty acid, all of the venous blood that drains from your abdomen, directly goes through your liver. So the more fat you have in your abdomen, the more you are bathing your liver in free fatty acid. When you expose a hepatocyte to high levels of free fatty acid, a hepatocyte becomes insulin resistant. So this is one of the primary drivers of hepatic insulin resistance, is this high amount of free fatty acid going through from the venous drainage of abdominal fat. So just walking in the door and seeing fat distribution can help you create a cardiovascular risk profile. In addition to just the distribution of fat, having a note of their BMI and noticing if the patient is obese would give them another kind of check mark in their cardiovascular risk profile. You know, just like in the pulmonary section, we do want us to look at posture. There's a lot of cardiac disorders that result in dyspnea and difficulty breathing. So difficulty breathing, use of accessory muscles, forward rounded posture, prominent clavicles, all kind of start to give you a picture that they might be struggling to breathe. Skin tone is an important aspect of their cardiovascular health. That pallor that you might see can be a sign of a activated sympathetic nervous system, which if their cardiovascular system is struggling to maintain hemodynamic stability, they're going to have a higher activation of their sympathetic nervous system, and that can result in pallor. Cyanosis would be a sign they're not getting enough oxygen delivery. All these things can help paint the picture of the patient you're about to walk into. So as you're kind of going head to toe, you want to evaluate their neck and chest. Specifically for our cardiovascular patients, you want to take a note of their jugular vein. So on this slide, you can see two images of people who have jugular vein distension, JVD, jugular vein distension. This is a sign of increased pressure in the venous circulation. So if an individual is experiencing right-sided heart failure means a failure to maintain cardiac output. If they can't pump the blood forward, the blood backs up in the system behind it. And the jugular vein is almost like a straight shot up off the right side of the heart. And you can see this as almost like a barometer of the pressure of the right side of the heart. So normally, the peak of your jugular vein kind of bulging, or where you could almost see the pulse, is somewhere between 3 to 5 centimeters above the sternal angle. So if you have someone lay down and you measure, kind of as you can see in the picture here, the distance between the sternal angle and the height of the highest bulge of the jugular vein, this should be somewhere between 3 to 5 centimeters. When it is greater than 5 centimeters, that is a positive finding for increased pressure on the right side of the heart. So if you're going to do this measurement, it's much easier to see jugular vein distension on the right side of the neck as opposed to the left. So in addition, you want to keep going down the way and take a look at their extremities. So it's really important to look for signs of peripheral edema. You can see here this individual has pitting edema in their foot. Peripheral edema would be evidence or would be a sign that someone is having pressure backing up in their venous circulation. So again, heart failure, it backs up fluid in the system behind it, and you end up seeing these signs of edema and increased pressure peripheral. The next thing you want to do is take a listen to their heart. So at this point in lab, we've had the opportunity of drawing the heart, so you can really get appreciation of the anatomy as it hides behind our rib cage. And you've hopefully had a chance just to listen to each other's heart during that lab, but we're actually going to go through the systematic auscultation of the heart now at this point in this semester. So by listening to the patient's heart, you can get an assessment of their hemodynamic function. And it's very helpful to listen to kind of the 4 key areas that represent the valves of the heart, to listen how blood is moving from one area of the heart to the other. So as you can see written in your notes and on the slide here, the 4 areas are the aortic area, pulmonary area, tricuspid, and mitral. So a way to remember these, if you go in order from top to bottom, is looking at the first 4 letters and remembering the memory tool of all physical therapists move. All PTs move. Helps you remember aortic, pulmonary, tricuspid, and mitral. And that is the order that you do your assessments. You start with the aortic, then you move to the pulmonary, then you go to the tricuspid, and then you go to the mitral. So all PTs move helps you remember the order and which represents which area of the heart. So a tricky thing with listening to the heart is the valve itself, like the aortic valve and the pulmonary valve, they all hide right behind the sternum. So you cannot hear through bone. So if you actually put your stethoscope right over where that valve is, you couldn't hear anything. So what these spots on the chest represent is the area the blood moves into when it flows through that valve. So we're kind of following the area of blood flow. When blood moves through the aortic valve, it kind of splashes up into the aorta, and that's where you can actually hear the noise. So if you'd like to write down the specific areas for each one, let's start with the aortic area. The aortic area can be found. I'm just going to erase those pen markings so we can see our area here. The aortic area is in the second intercostal space, just to the right of the sternum. So the aortic area for auscultation is in the second intercostal space, just to the right of the sternum. The second area is your pulmonary area. And the pulmonary area is directly next to the aortic. It's also in the second intercostal space, but now you go just to the left of the sternum. So you start on the second intercostal space on the right, listen to the aorta, move over to the left, and you listen to the pulmonary area. We'll go through the heart sounds, but lub-dub represents S1 and S2. S2 can be heard more clearly at the aortic and pulmonary area because the start of diastole is the closure of the aortic and pulmonary valves. So when you're at the aortic and the pulmonary area, your S2 sound will be the most distinct. You then can go down to the tricuspid area. The tricuspid area to listen is between the fourth and fifth intercostal space at the lower edge of the left sternum. So between the fourth and fifth intercostal space at the lower left-hand side of the sternum. And then the mitral, you follow that fifth intercostal space out and you go right at the mid-clavicular line to get the mitral valve. So here it kind of represents our mid-clavicular line. So the tricuspid and mitral valve, right, those are the valves that close at the start of systole. Right as that ventricle is building up its pressure, it snaps those valves closed. So at the tricuspid and the mitral area is where you hear S1 louder and more clearly out of the four areas. So it's really helpful to remind yourself of the cardiac cycle when we go to do auscultation of the heart. So I've just mentioned this in the previous slide, but let's just go through kind of what we are actually hearing. So when you listen to the heart, you hear a clear lub-dub, lub-dub, lub-dub. The lub of the lub-dub represents S1. S1 is your first heart sound. S1 represents the start of systole. So S1 represents the start of systole. Systole begins when you close the mitral and tricuspid valve, the beginning of the isovolumic contraction. So at the end of diastole, the ventricle begins to contract. And we're starting at this very low pressure. So what we're looking at on this picture are our pressures within the heart. And the red line is your ventricular pressure. Ventricular pressure at the end of diastole is very low. And you begin an isovolumic contraction, meaning you don't yet change the volume because the aortic valve is still closed. But as soon as the pressure in the ventricle, as soon as that pressure in the heart starts to build, it snaps the mitral valve close. That allows all the blood that just got in through that primer pump from the atria to stay in the ventricle and not have regurgitation backwards. So as soon as you begin your isovolumic contraction of systole, the mitral valve and the tricuspid valve snap shut, and that makes the sound. That is the sound of S1. So S1 would be louder and longer at the apex or the mitral valve area and in the tricuspid region. All right, so your ventricle is contracting, the mitral and tricuspid valves snap shut, the pressure continues to build until the pressure in the ventricle exceeds the pressure in the aorta. At that moment, your aortic valve opens, and now we actually get ejection of blood out of the heart. You have a little overshoot in pressure, but then you're going to start to lose pressure because as blood is leaving, the pressure within the ventricle is going to start to go down. The heart begins to relax, and as soon as aortic pressure is greater than the pressure within the ventricle, the aortic valve is going to snap shut. So as soon as the pressure in the aorta exceeds the pressure in the ventricle, the aortic valve snaps shut, and that makes a noise. That's S2, our second heart sound. That is the dub. So S2 is the closure of the aortic and the pulmonary valves, which is why it's easiest to hear in the aortic and pulmonary region. S2 is a sound that gets louder when someone has pulmonary hypertension. So if S2 is the sound of the aortic and the pulmonary valve closing, if someone has pulmonary hypertension, it's going to really snap that pulmonary valve shut, and the sound becomes louder. So a very loud S2 is a positive finding for pulmonary hypertension. So S1 and S2 are our normal heart sounds. That's what you'd expect to find. S3 and S4 are abnormal heart sounds. They shouldn't be there, and when you hear them, it can be a sign of a pathology. So let's first talk about S3. S3 you can see here in the figure. S3 occurs very early in diastole, because remember S2 represented the start of diastole. So very early into diastole, you hear an extra sound. And as it says in your notes, it's sometimes written as a lub-dub-dub, lub-dub-dub, lub-dub-dub. And the beat can be helpful to remember that it goes with the sound of Kentucky, Kentucky, lub-dub-dub, lub-dub-dub. When you want to listen for an S3 sound, this will be easier to hear if you use the bell of the stethoscope. It's a very low-pitched sound. S3 can be easier if you think you might hear something abnormal and you're not sure and you want to listen for an S3. If you have the patient lay on their left side, the whole heart will move closer, and the apex of the heart will be the closest it can be to the chest wall, and it can make that sound more pronounced. So that can be a helpful trick if you thought you heard something and you can't quite make it out. If you have the patient lay onto their left side and auscultate at the mitral area, you might have the best chance of hearing it. So what does S3 represent? Why is there this extra dub at the beginning of diastole? S3 is sometimes referred to as a ventricular gallop because it is a key diagnostic sign of ventricular dysfunction. Let me say that again. S3 is called a ventricular gallop because it is a key diagnostic sign of ventricular dysfunction. If the ventricle has lost its compliance, it's not very stretchy, or if the ventricle is under volume overload, then at the very beginning of diastole, when the blood starts to enter the ventricle, blood is going to be entering either a high pressure or a high volume system, and it makes this extra noise. So S3 is the sound of blood entering the ventricle at the beginning of diastole to either a high pressure or a high volume system, and that makes a reverberating noise that you can hear. Because of this, S3 is the classic abnormal heart sound that goes with congestive heart failure. Congestive heart failure is a failure of the heart to maintain cardiac output So there's extra volume in the heart. It can't get all that blood out. So as soon as diastole starts, blood is now entering a high pressure or a high volume ventricle. So the presence of S3 is a positive diagnostic finding for heart failure. The final abnormal heart sound is S4. And S4 is when you hear an extra sound very late into diastole. So that extra sound comes kind of right before the lub. A helpful way to remember this kind of the rhythm of S4 is that it goes with Tennessee, la lub dub, la lub dub. It's just this extra beat right before the lub dub. Just like S3, S4 is better, is easier to hear if you use the bell because it's, again, a low-pitched sound. S4 is associated with the atrial contraction or that primer pump. When the atria contracts into a high volume ventricle, you can get what's called the atrial gallop. So there is, S4 is kind of seen when there's increased resistance to ventricular filling. So in hypertensive cardiac disease, some pulmonary disease, after someone's had a myocardial infarction or a CABG procedure, sometimes you can hear S4 with serious coronary artery disease, that when the atria tries to give that last little boost of blood, there's resistance to that primer pump and it makes an audible sound. Now, we will have the opportunity in lab to hear all of these, both on the mannequin, and I'll help get you guys logged into an easy website that you can listen to at home called easyauscultation.com, so you can get practice hearing these sounds. It's important to know that truly being able to discern S3 and S4 is considered an advanced skill. There was a study done and I can't remember the percentage now, but a really large percentage of cardiologists were still inaccurate at truly naming cardiac sounds. So if you hear something that's abnormal, it's important to communicate that to the medical team, even if you're not 100% sure if it's an S3 or an S4. It's helpful to listen to the heart. It's really helpful to note if there was no abnormal sound before activity and then an abnormal sound appeared after activity, even if you're not 100% confident if it's an S3 or S4. You can clearly know that it was not there before and now it's present, and that can be a really valuable piece of information for the medical team. So if you have a hard time when you're practicing this in lab, please know that heart sounds are very tricky to discern accurately between the two. And in real time, just the presence of an abnormal sound is an important finding. So at the bottom of your note page is heart murmurs. Now, heart murmurs are incredibly complex, but they kind of fall into three rather broad categories. The sound of a murmur, generally speaking, is you're hearing turbulence of blood flow. Okay, so a murmur represents turbulent blood flow, and it comes from kind of three broad categories. Either you have really high flow. Excuse me, I just had an interruption, so I'm going to start that one from the beginning. It either comes from high flow through a normal or abnormal valve, forward flow through a constricted valve, or backward flow through a valve. Any of these kind of broad categories can cause blood turbulence and can result in the sound of a murmur. The last one for our abnormal heart sounds is pericardial friction rub. Pericardial friction rub is a sign of pericardial inflammation or pericarditis. It kind of sounds like you have a creak with each beat of the heart. It's sometimes referred to as a sound of like two pieces of leather being rubbed together. But an extra creak is representative of inflammation around the heart. The next piece in your assessment is the evaluation of circulation. This is incredibly important, and I know you guys covered some of this in your wounds class, as kind of improper circulation is a major cause of a lot of the wounds that you guys have learned about and that we as physical therapists can help with the treatment of. But in this class, it's really important to consider the role of circulation as part of your cardiovascular assessment. So evidence of poor circulation can certainly be felt with your peripheral pulse. So in lab, we'll have the opportunity of palpating all of the arterial pulses. You know, clinically, even though they're the most tricky to feel, we probably use, in terms of evaluation of circulation, both the posterior tib and dorsalis pedis a lot to see how well the blood flow is getting to their feet. So I really want you to practice and get comfortable with that skill. If a patient's pressure is really low, it can be so hard to feel that you may need to use a Doppler, and we'll practice that in lab as well. Other signs that of representing poor circulation can be trophic changes to the skin. Trophic changes to the skin can be picked up just with visual inspection, and it kind of might look like hair loss, muscle atrophy, very dry skin. This can lead to dry gangrene and ulcers. So where you see that kind of shiny, hairless skin, that can be a sign of poor circulation to that region. You can measure and assess reactive hyperemia by sharply elevating the limb to produce blanching. The skin would look white. When you return the foot down, it should kind of go back to its normal color within 15 to 20 seconds. If you have inadequate blood supply, it can take longer for the blood to return to the foot. So greater than 20 seconds is evidence of inadequate blood supply. If, after you have sharply elevated the foot, you descend it, someone's skin becomes dusky red, that's an incredibly bad sign. That shows you that the tissues were hypoxic during elevation. You can measure skin temperature, as that is a way to reflect perfusion. You can also really describe the quality of the pulse that you observe. You want to compare right to left, and you have a rating system that you can use to describe your pulse. So a +2 is a normal pulse, and as you can see here, +1 is diminished, and 0 would be absent. You cannot feel it at all. You can also use a scaling system similar to this if you have a really exaggerated pulse, sometimes referred to a bounding pulse. So pulse +3 would be kind of a full pulse with even a slight increase in volume, and a +4 would be a bounding pulse. This would be signs of hypertension or something else that's raising arterial pressures. And then a really important part of the cardiovascular assessment is going to be your activity assessment. And we've obviously introduced this in all of our pulmonary cases, but this is a key element to their cardiovascular system and how well it responds to activity. Any patient should have an activity assessment as soon as they are medically stable. You can assess patient's activity when they're still on a mechanical ventilator. After a heart attack, as soon as they can get out of bed, they want to get them up and seeing how well they're tolerating that activity stress. So when you are going to do an activity assessment, the most important thing is to get a resting value, right? The response to activity is only as good as it is changed from rest. So many patients that are going to be getting a cardiac assessment would be on a monitor, which provides you with a lot of real-time information that can be very helpful. So every monitor is a little different, and you want to make sure you're acquainted with what you're looking at. At the top here, we have heart rate, which is where you can see your EKG output. On this screen, our second value down is our oxygen saturation. That waveform is really important to tell you how good of a signal you're getting. This monitor has a respiratory rate recording, and the NBP is the non-invasive blood pressure. So this patient is not on an arterial line, and you would need to actually take their blood pressure by pressing a button on the screen or near the bed to have the cuff inflate and get a new value here. So if it's a non-invasive BP, make sure you take that blood pressure right before you do your assessment. So blood pressure obviously can be affected by a whole host of things. This can give you, some assessment of their cardiac output. That diastolic number gives you an idea of their total peripheral resistance. You can see changes in blood pressure with changes in blood volume, and that might come with changes in electrolytes that might match up with their lab values. Their viscosity of blood, neural input can all have an effect on blood pressure. A number of meds do as well, so it's really important to coordinate what you're seeing with their blood pressure with what kind of pharmacological agents they are on. This is just a place to have in your notes another reminder of our blood pressure ranking and how we actually identify someone in the range of hypertension. You will also take your heart rate measurement. And it's really good to become comfortable with thinking about a patient's heart rate as it would relate to their predicted heart rate max. So for anything in this class that's using heart rate max as a percentage of or how you prescribe exercise, we always want to use the Tanaka, as that is a more accurate formula. 220 minus your age is maybe a little easier, but it underestimates maximal heart rate in well-trained individuals as well as the elderly. So Tanaka is more accurate of the kind of predictive equations. It would be good, even if they're on a monitor, to take a peripheral pulse yourself. That's how you get the quality of the pulse that we talked about on the previous slides. And you can take a radial pulse and look at their EKG. This is where you can see the electrical activity and then feel that response peripherally as the bolus of blood comes out. In lab, we're also going to encourage you to take a radial pulse when you're listening to the heart, because the radial pulse should really match up with your S2 heart sound, right? The start of diastole, when the bolus of blood has left the heart. Heart rate response is incredibly important to know how it's going to respond to activity. And so you always have to remember what you expect to happen. There should be a gradual rise. And an exception to that would be patients who are on beta blockers. That's good. You would then expect a blunted heart rate response. If you see a really rapid rise in heart rate to activity, that can be a sign of severe deconditioning. It can also be a sign that your cardiovascular system is not appropriately raising stroke volume. Something's limiting stroke volume increase. So they're compensating by using heart rate to maintain cardiac output. There may be a flat rise or a bradycardic response, and if they're not on a beta blocker, that would be an abnormal finding. If you see a decrease in your palpated heart rate response to activity, it is almost always not truly a reduction in beats. It's a reduction in palpable beats, and that's a big difference. So if you're feeling a radial pulse and in response to activity your heart rate goes down, that is almost always a sign that they're experiencing an arrhythmia. If the heart is going into an arrhythmic beating pattern, they're going to be less efficient at making one big bolus of blood. So when you're feeling out in the periphery for that bolus of blood to go past your finger, if the heart is beating it in an uncoordinated pattern, you're not going to get the same big rush of cardiac output, and you might actually feel that as fewer beats. Obviously, an increase in arrhythmias in response to an activity is in itself an abnormal finding. So it's never good to have the palpated heart rate go down. It's just if you're actually thinking about what's happening, in many cases, the heart rate is actually electrically higher than normal because they're into an arrhythmia. So heart rhythm kind of flowing right off of that, should remain regular with exercise. It's an abnormal finding if someone develops an arrhythmia when they are exercising. Now, it's important to know that while a reduction in heart rate may be suggestive of an arrhythmia, you cannot determine a patient's arrhythmia without an EKG. There's nothing palpable, there's nothing to listen to. They need to be on a monitor if you're going to be able to identify what the arrhythmia is. Anytime you encounter an arrhythmia, you should ask yourself these 4 questions. Is the arrhythmia a new finding? This is an incredibly important question because if the patient has known atrial flutter and it's documented in their chart they have atrial flutter, then you walk in your room and you see atrial flutter, this is not a significant finding. It's a well-documented finding and it's being handled in whatever way is appropriate for that patient. If there's no mention in the chart, there's no mention from nursing, and you walk in the room and observe an arrhythmia, this is a much more significant finding. The next question you ask is this arrhythmia benign or life-threatening? So even if you answer to question number 2, is it's new, answer question number 1 is that the arrhythmia is new. Number 2, you might recognize that it's a benign arrhythmia. You'd want to document it and report that this is a new finding, but it's not nearly as significant. Obviously, if you observe a life-threatening arrhythmia, it is going to require immediate action. The third question you ask anytime you encounter an arrhythmia is, could their meds be producing this arrhythmia? There is a whole host of medications, and we will go through this as we kind of do review of some of the cardiac meds that cause arrhythmias and will make this less of a surprising finding. And then fourth, always assess the symptoms that you are seeing in the patient in front of you. If you see something really wacky on their monitor and they're sitting comfortably in front of you, you're going to react very differently than obviously if they're having significant symptoms related to reduced cardiac output. So you want to do an activity assessment to evaluate their cardiovascular system. And I include this slide just as a reminder that if you are going to do an activity assessment for the value of gaining insight into the cardiovascular system, you have to take these measurements during the exercise. On this slide, you can see cardiac output, stroke volume, and heart rate. You begin to exercise, and you see this nice gradual increase as the cardiovascular system ramps up, and then an eventual plateau when they reach steady state. Steady state is where you want to take your measurements. It can be helpful to observe the ramp up, but you want to make sure you're taking an assessment when they're exercising. If you wait until they sit down and then you take your measurements, you are taking a recovery measurement. And you can see that almost immediately the cardiac output, the stroke volume, and the heart rate plummet. So even if you are the fastest vital taker in the world, these values are going to be lower when you take it, if you have the patient stop their activity when you take the measurement. So in phys ed activity, you had the opportunity to take a bunch of active blood pressures. We're going to practice in lab, taking them when they're walking, just as you would be kind of walking the halls of the hospital. But it is important to feel comfortable and take the measurements when the activity is happening to truly get as much data from your activity assessment as possible. So for each variable, you want to feel very comfortable with what should happen. What is the normal response to activity? So for heart rate, there should be a gradual rise, and then it should level out once you get to a steady state. Systolic blood pressure should have a gradual rise. Diastolic blood pressure shouldn't change much with activity. Diastolic blood pressure represents the total peripheral resistance. So as cardiac output goes up, you also get this massive vasodilation, which offsets the changes in the total peripheral resistance. Your oxygen saturations should not change during exercise. We have so much reserve in our pulmonary system that we can handle this increased oxygen demand without any change in our blood values. And then respiratory rate has that gradual rise. Obviously, it gets kind of exaggerated when you get up into the higher levels. So by knowing how they should normally respond, you can be quick to identify an abnormal response and either stop the assessment or document that finding, as it might be a significant piece of their medical story that can help guide their therapy overall or their medical treatment overall. All right, that's your quick and dirty introduction to the cardiac assessment. Now let's start using this with some cases. We will spend a little time on the specifics of an EKG, and then we'll jump into some cardiac cases. Thanks for your attention.